Okay, we're going to get going. We're going to probably have to beef up our in-person attendance. I know a lot of people are online. So we have two talks this morning. The first one is how we get reimbursed, the RVU and the RUC system. It'll be presented by Dr. Joe Cleveland, who's a professor in the CT division. He did his undergraduate training at USC, medical school training at University of Washington, and then came to the esteemed University of Colorado for his general surgery training as well as his CT fellowship. He's been on faculty here, has held many leadership positions around the world and especially nationally in the Society of Thoracic Surgery and many other places, is heavily involved in how surgeons get reimbursed. That's why this talk is so important. I think many surgeons go around not really understanding what actually gets done and how these numbers are figured out. Dr. Cleveland has also extremely ably served as a vice chair of faculty affairs and has been involved in all the promotions processes for the faculty in our department, and really has had, I believe, 100% success rate in putting our faculty up for promotion. He's a technically excellent surgeon, has mentored many people, both clinically and through his research projects. And I don't think this is a well-kept secret, but he's about to be appointed our next division chief of cardiothoracic surgery. And with that, Dr. Cleveland, I invite you up. Thank you.
Can everybody hear me? Thank you, Dr. Schulich, for that very kind and gracious introduction. So this morning, in the next 30 minutes, I'd like to explore the relatively complicated world of physician reimbursement with us. We'll start with a brief historical overview, then move to understanding what Dr. Schulich alluded to, which is a resource-based relative value scale, mouthful, RBRVS, and the RVU system, how relative value units are developed and valued. Lastly, we'll close with some of the challenges for us in the House of Surgery as we move forward. So my only disclosures are that I serve as a voting member on the RUC for the Society of Thoracic Surgeons. I also serve on the Plastic Expense Committee or subcommittee of the RUC. So where did all this start? Well, it started in 1965. Pictured here is President Johnson with President Harry Truman in Independence, Missouri at the Truman Library. This is the place where President Johnson signed into law the Medicare Act, 1965, which provided federal health insurance for elderly, defined as someone older than 65, and people of low income with Medicaid. The significance of having President Truman here is that actually President Harry Truman was the first president to propose having federal health insurance in the United States. This was shot down by Congress as the federal government has no role or should have no role in health insurance, and this will lead to socialized medicine. He also enrolled President Truman as the first beneficiary in Medicare. So as we work through this, a couple things to keep in perspective. One is population. The second is what's happened in healthcare. So in 1965, the life expectancy for a male in America was 66.8 years. For a female, it was 73.8 years. So when this law was signed into effect, the actuaries kind of thought, well, we can cover men for a year or two and women for about 7 years, and then we're good. Well, flash forward to now, average life expectancy approaches 80. So we've got 15 years of carrying people. And then lastly, I'll use the treatment of myocardial infarction as a paradigm for this. So in 1965, if you had a heart attack, what happened? You went to bed rest, you had your blood pressure taken, you maybe got an aspirin. Flash forward to 2022, you get a heart cath, get a bunch of medicines, you get either a stent, bypass surgery, or God forbid, if you have the big one and your ejection fraction is 10%, you get put on a transplant list, you get a heart pump. Obviously, the resources that now are available and the costs associated with them could not even be fathomed in 1965 when this was signed into law. And as such, here is the amount of federal spending on healthcare. So 3% of the Medicare consumed 3% of the federal budget in 1972, 13% today. Flash forward another 30 years, it'll be a fifth of our federal budget, Medicare. So we went by one, a couple of housekeeping issues. So let's talk about Medicare in the early years, 1965 through 1985, and a few housekeeping issues. First of all, when we talk about Medicare holistically, Medicare has several subdivisions. Part A is the hospital part. So that's a part that pays hospitals. Part B is what we're going to talk about today. It's what pays doctors. So back in 1970, say if Dr. Schulich were out doing a Whipple in 1970, he would file a charge based on customary, prevailing, and reasonable charges. He could send a bill to Medicare for $3,000. Dr. Del Chiaro, in 1970, could send a bill for $4,000. Depending on where you were in the country and some other things, Medicare would pay those bills differently. So there's a lot of variation in how doctors got paid. And in the first kind of escalation of rapid increase in healthcare costs that happened right around this time in 1980, payers, policymakers became dissatisfied with this, and physicians did too, because why would it make sense that you pay Dr. Del Chiaro and Dr. Schulich differently for the same work? So on the hospital side, the solution was to go with diagnostic related groups, DRGs, capitated payments. You get admitted to a hospital with pneumonia, boom, there's your bucket of money for the hospital to pay for that. Doctors weren't so easy. So as we came into the mid-1980s, this thing's jumpy, we really had four things available to us. We could modify the customary, prevailing, reasonable charge setup. Again, people weren't happy with this. We could borrow the concept of capitated payments from the hospital side, and apply it to physicians. There was a lot of rebellion from the physician voices at that time. We could force physicians into basically large healthcare organizations, capitated plans for payment, pay them that way. So as I'm kind of walking through these, I want you to think, is this that much different than where we are right now? Not really. Or we could develop a fee schedule based on resources and a relative value scale, the RB-RVS. And so the way that basically conceptually comes about is this. You have service A that takes you twice as long in minutes to perform. It's twice as difficult and requires twice as much expense, that is non-physician personnel, office space, equipment, than service B. Well, the relative value of service A is 2x that of B. And you go on and on through the 10,000 different CPT codes and establish a scale. So where did this idea come from? Well, this idea came from Harvard, from a healthcare economist, William Zhao, and internist, Peter Braun. What they did is they developed an entire conceptual framework defining costs, resources, and estimating physician work. They kind of floated this trial balloon through 12 different specialties, shown here in 1985. So in their seminal publication, an overview and development and refinement, the resource-based relative value scale, and look at the subtext, the foundation for reform of US physician payment. This is how it works. I'm going to show you how it works for surgeons. So most of us work under a global 90-day payment system. So that is, if you do, quote, major surgery, your physician reimbursement is based on a 90-day payment. For other things like urology and office-based procedures, they're 10-day and 0-day payments. But the way it works is starting here with one, your initial consult. So that is where you see the person in the office. You see somebody in the office that has an inguinal hernia and decide they need a hernia operation, okay? That's a separate bill that gets billed under an E&M code. The day the person hits the operating room, so the pre-service period defines where you go see the person in pre-op. You write a quick H&P, you check the orders, you make sure that they still want to have an operation, that kind of stuff. You get in the operating room, and believe it or not, you get 3 minutes of time given to you for waiting while they get dressed, while you scrub, the patients are prepped. And then if there's other, like if you're doing a lithotomy procedure, or flipping somebody in their back in the middle of procedure for some of the spine procedures, you get a little extra time. But then the intra-service work, that's the meat of the operation. That's from incision to closure. You then get a same-day visit, a post-op care visit, and then depending if the patient goes to the ICU, hospital post-operative visits, and other post-operative visits. These post-op visits and then office visits that extend all the way out to 90 days are built into the package. And so if you look at this, about 15% of the RVU, relative value unit time, is built into here. About 60% is here. And about 25% starts from 0.5 on. And the reason I'm telling you that this is important is that one of the things that's come under attack in the physician payment system from Medicare is these post-operative visits. They don't think we're seeing our patients post-operatively. There is a strong movement inside CMS to abandon global surgical payments, quit paying this 25% of our reimbursement. We'll talk about that a little bit. So this is critically important to understand this. So again, as we move through history and how this thing starts to develop, the RVS was signed into law when Congress passed OBRA. And they said, this is going to be the construct for medicine for how we pay doctors. We were going to pay them on relative physician work. We're going to actually value their practice expense. So that's all the non-overhead type stuff. So to run a practice, turn on the lights in a building, pay a lease, we're not paying for that. But if you're seeing people and there's certain expenses associated with an office visit, you look in somebody's eyes, you have an otoscope, you look in somebody's ears, you got to have those little disposable ear cap things to throw away. Medicare pays for those. And a very small part of this is actually professional liability. So what we pay for our liability insurance. There's some small geographic adjustments. One of the things that Medicare did is it did away with this idea where you can pay doctors differently. And we're not going to pay specialties differently. So for a while, plastics might get paid something for a hand thing versus ortho hand. That's gone. We're supposed to pay specialists and all doctors differently. And then here's the last thing on the slide that's absolutely critical for us to understand. So Congress calculated in this because of the concern for, well, if we just write these doctors a blank check, we're going to have escalating costs. They capped it. So they have a budget neutral process. So by law, we cannot put more than $20 million a year into Medicare Part B than we did last year. So the analogy is we've got 75 people in this room, maybe 50 people right now. Dr. Schulich says to his office staff, let's get coffee and bagels for 75 people. Let's say all of a sudden that increases to 150 people. We still have coffee and bagel for 75 people, and that's what we divvy up. So for an increase in RVU in one group of the House of Medicine, everybody else pays for it. New codes come along, TAVR codes come along, everybody pays for it. So that's a critical piece. We don't get any more money each year. And we're the only part of the federal government, by the way, that works. So how do we define physician work? So physician work is basically the product of time multiplied by intensity. So obviously the kind of ordinal calculated thing you can measure pretty easily is time. Intensity is a little bit of a fuzzy-wuzzy thing. Intensity is, okay, well, how much mental effort and clinical judgment does it take? How much technical skill and physical effort is involved? And what's the stress due to risk? You know, what's the stress that if I'm a primary care doc and I miss an otitis media and the kid's got to go to the ER, well, there's some stress with that. But obviously for us in our house of surgery, if an anastomosis doesn't work, falls apart, or I catch a back wall sewn a coronary, there's a lot of stress and risk associated with this. But when you try to make these more intensity-based arguments for an RVU at the RUC, they don't fly as well as time. Most of the survey that we look at is time. So when the Harvard RVS system first got rolled out, basically this was done by basically some technical consulting panels. You know, Congress signs this law and then says, okay, go make this work. The Harvard group gets on the phone, interviews 2,000 physicians, does a lot of things. It's an extraordinarily contentious process. And the reason why is because just like in America today, it divided the House of Medicine into two camps. You're either a cognitive physician or you're a procedural physician. And the cognitive physicians were, kind of the internists with the, sitting in the office thinking, boy, this person with blood pressure, could they have a FEO? Could they have this, having to generate these differentials? Or procedural physicians. But as we know in surgery, that's kind of a ridiculous argument. I mean, while Dr. Schulich's doing a Whipple, do you think he's not thinking? That's just an argument that doesn't hold water. So many of the specialty societies, and particularly the surgical societies, really disagreed with these valuations and said, we are being undervalued as proceduralists. We're just not people that show up and just sew A to A prime. In fact, our own society, the Society of Thoracic Surgeons, I think Fred Grover can remember this, hired an external consulting firm, the AB Associates from Cambridge, which is a think tank that basically kind of went through, surveyed our own specialty and said, over half these codes, we completely disagree with what these RVUs, these relative value units that you've set from Harvard. So what we had at this time was kind of a massive traffic jam. House medicine is very divided, coming at CMS, coming at government saying this doesn't work. There's no framework. So what we needed was a traffic cop. So that traffic cop was the AMA. And the reason the AMA was chosen as a traffic cop is because of its long-standing role in developing the CPT code process. So these 5-digit codes that are associated with what we do, everything from evaluation management to redo liver transplant, has a 5-digit code. The AMA developed these. And so CMS and Congress worked with the AMA, and then what came out of the AMA was going to the different specialty societies and saying, we're going to form a thing called a Relative Value Scale Update Committee, the RUC. It was formed in 1991. And the charge of the RUC is to make recommendations to CMS on relative values. That is basically to take a CPT code and say, what is the RVU for this code? So what is the RUC? Well, it's a 32-member panel, 32 members vote. 22 of those members are appointed by national major specialty societies. 4 seats rotate, primary care seats that rotate, and there are 6 remaining seats for the chair, co-chair, and some other things. Here are the permanent RUC specialty seats, and you can see that, if you will, the House of Surgery is pretty well represented in here when you look at things like OBGYN, orthopedics, thoracic surgery, general surgery, otolaryngology, plastic surgery, urology. So we've got a reasonable, but the majority of these seats are, if you will, tend to have more of a, if you will, kind of internal medicine or primary care basis. It takes, by the way, 2/3 vote to get a RVU code passed. And so keep that in mind when we take our codes to the RUC. There are 5 different subcommittees for the RUC. The practice expense is a pretty active committee that obviously values the practice expense, and I'll show you. The total RVU that's developed is a component of physician work, practice expense, and liability. As I mentioned, practice expense is not trivial. The other group that's fairly active is a relativity assessment work group. So this group is a group that kind of is a subgroup of the RUC that goes through and says, we think certain codes have been valued, but they're misvalued. We need to relook at these. It's kind of like, and the way that this usually works is CMS contacts the AMA and says, we want the RA to look at this. So we think this is potentially misvalued. And it usually happens when a certain code starts to really increase very exponentially in its use. So again, walking through this complex flow sheet, so either CMS or through the CPT editorial process. So you develop a new procedure, you get a CPT code, and or CMS takes this, it takes it to the specialist societies themselves, and then they survey physicians. And so you may see every now and then a blast email come out from the American College of Surgeons. We're surveying hernia codes. We need you to fill out this survey and tell us, based on this typical patient we'll give you, how long does it take you to do this procedure? What are your usual post-op visits, et cetera? It's very important that people fill these out. A lot of people, they go to their empty box or their wastebasket, but it's really important you fill these out because based on these survey values, the specialty society then comes to the RUC with a survey between 30 and 50 physicians. Believe it or not, that's all it takes, depending on how many times this procedure is done. So if it's done like over 1 million times in the United States, you got to have 50 doctors answering the survey. It's done less than 100,000 times, you need 30 to have a valid survey. The time is averaged, you get a median time, post-op visits like that are counted in and things like that. The RUC debates what the proposed RVU is from the specialist society and either accepts it or says no. And what we really look at is, again, placing it usually with a couple anchors of things that are above it and below it and saying, yeah, this seems like about the appropriate RVU for this. Again, it's relative. You put it in concert with other things that are done. We then send that valuation to Medicare, and Medicare either accepts or rejects the process. Now, interestingly enough, since in the early days of the RUC, from 91 to about 2012, Medicare would accept about 90 to 95% of the RUC's valuations. Since 2012, it's about 65 to 70%. That's one of the other challenges in this process, because as Medicare decides to arbitrarily sometimes go through and say, we don't like this RVU, and it's never they're gonna increase it. It's always, we don't like this, we think it's too high. As they do that, there is a chance that we can have rank order anomalies. That is, since we've based some of this relativity on each other, if they pick out certain codes, say this is too high, knock it down, we may actually then incur rank order anomalies in this. It's what the thing looks like. It's held in Chicago 2 times a year. The winter meeting is somewhere warm to get the Chicago staff out. But presenters sit at this end of the table. This is the panel itself voting. Here are all the people, there's usually about 300 people in the room from specialty societies, insurance companies, CMS is there. A lot of people are there listening to what goes on. So how do you actually turn RVUs into dollars? Well, this is the way the process works. So the work RVU that comes out of the RUC, the PACS expense RVU that comes out of the RUC, the PLI is determined by a formula that is much more formulaic. It's not really looked at. So these two are basically adjudicated by the RUC. They're multiplied by a geographic practice consideration thing, which is tenths of percent. So very small, but you basically add these three up and get a total RVU. Now, again, as I mentioned, practice expense is not insignificant. So of the total RVU, only 50% is physician work. 45% is practice expense and 4% is PLI costs. So practice expense, again, being things like office supplies, office personnel to do this procedure, particularly, and there's facility and non-facility based things. So most of our work is done in a facility here. So we have very little practice expense. Most of our stuff comes from the physician work side of things in the house of surgery. But that's not true in ambulatory settings. In ambulatory settings, over about half the RVU is valued based on practice expense. So this is how this turns into dollars, and the total RVU is multiplied by a conversion factor. That gives you the dollar that Medicare pays you for a procedure. So the conversion factor is set each year by Medicare. It's based on three factors, and it's really this last one, but they claim to use the Medicare Economic Index, CMS does, but every year. And so the Medicare Economic Index is factored off the census data, and CMS always looks at it and says, well, we're not really sure what's happening with economic index for this, so we're just going to leave this neutral. There's an expenditure target, which, as I mentioned, budget neutral. So last year we spent $800 billion for physician payment. Now that's in context of Medicare spending $4.1 trillion overall. It ain't going to change by more than $20 million of $800 billion. And so that's 0.0025%. So the conversion factor in 2022, this last fiscal year, was $34.61. Well, Dr. Schulich alluded, University of Southern California was part of my undergraduate education. You cannot escape USC without becoming a huge college football fan. So the one show that I watch every week, regardless, unless I'm in the OR, is College Game Day, because I love college football. And my favorite is Coach Corso, because as the panel sits and debates things and says this and this, he's always so good at saying, not so fast, my friends. And so, right, here it is. We've calculated our dollars, we take our paychecks, we walk off. Well, not so fast. There's some challenges for us in the system. And let me show you why it's under stress, like all of our healthcare system delivery is. So here's a graph depicting what Medicare has paid hospitals, both for inpatient, outpatient skilled nursing facilities since 2001. And here's what it's paid doctors as a percent change. So you can see hospitals have increased their charges and been able to generate 60% increase from Medicare. Us, we're flat. We actually take into account inflation, we're actually down 20%. The final rule was just published last Tuesday, November 1st. So the final rule is where Medicare comes out and says, this is the way the physician payment and actually all of payment, hospital Part A, Part B is going to be. And in the final rule, they set the conversion factor for the following year. So this year, when you look through all the 3,300 pages of the final rule, and who has time to read that? None of us. You come down to this synopsis. With budget neutrality, which is required by law, blah, 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 the required statutory update, the conversion factor of 0%, and the expiration of the 3% supplemental increase, we were getting 3% of an increase for MACRA, for the Affordable Care Act, for some of the quality payments. That expired in 2022. We're going to knock the conversion factor down from $34.61 to $33. So we're going to multiply that RVU by $1.55 less in this next calendar year. So it's a 4.5% decrease. Well, the other thing that's just so everybody knows, so the mandatory things that get paid in the government, Social Security, Medicare, in 2010, there was a thing called pay-as-you-go enacted. So pay-as-you-go said, we can't add to the federal deficit. So if we're adding to the federal deficit by these mandatory spending programs, we have to automatically implement a 4% spending decrease in those programs. So now you had this 4.5% decrease on top of 4% decrease. You see that we're going to get, and you had the consumer price index raging along at 8%, that actually could do the dollars, we're down 15%, 2023. And then the other ominous part of this is what CMS has been, as I said, we're under attack for globals. This is their strongest language to the yet, saying that they're going to want to improve global surgical package valuation and pay more accurately for the global surgical packages. This is Medicare speak for globals are probably going away in the next 3 to 5 years. We're gonna have to pivot to something else. So as surgeons, we're not used to just sitting back and kind of looking at things with an action. So we have an active surgical care coalition by we that's headed by the American College of Surgeons, but a lot of specialty, there's 14 different specialty societies involved in this. It's an active lobbyist. It's what you have to do. You got to go lobby the government so we don't get cut. There is a bill in the House this year, HR 8800, introduced by Representative Barra and Bouchon, bipartisan, a Democrat and Republican, to at least undo the 4.8% decrease. So again, just knock us back to the conversion factor where we got from. But this is kind of how we're living right now. And I can tell you, I don't think this is sustainable for us. And obviously nobody in this room is, not going to make their house payment, rent payment. We're not looking for our next meal, but what other profession, law, architecture, engineering lives each year having to go to Congress and saying, please don't cut us 4%. Please don't cut us 4%. It's time to do something different. So with that, I've left the whole 3 minutes for questions, but the bottom line is that we're not getting less complex in our healthcare delivery. The physician payment system is complicated. The challenges for the future are certainly how are we going to pay for not only us, but just all of things. Budget neutrality is a big, big elephant in the room for us. It really is difficult to work around this and say we're going to actually be able to reverse this. And the 90-day global, I think, is a specific threat to the House of Surgery that we need to keep an eye on. Thank you. Try to put at least a sunny facade on the first part of this talk.
Yeah, I'll ask a question, and that is, tell us a little bit more about how the sausage is made. I'm sure you have some interesting stories.
I have some great stories. First of all, it's relationships. And so I can tell you when I was first appointed to the RUC, the first thing I did was, you meet with these people 3 times a year, and I sought out the primary care doctors and I had lunch with them. I got to know them. So I could be able to have sidebar conversations with them, because just like it's politicking, you've got to be able to talk to them and say, hey, when the hernia codes came to the RUC 2.5 years ago, these were the first attack on the House of Surgery. They were undoing a lot of the globals and saying, we're going to put them at 0-day globals. And I said, we need to at least support increasing the intraoperative portion of this work so we can kind of recover some of this stuff. You realize with that 2/3 mandate, you got to get a couple of the House of Family Practice on board to realize they're going to have to give up a small part of their RVU. So that's the first thing. The second thing is that, and by the way, this is off the record, so we're not supposed to do that, but we all know we do that. So that's the first thing. You develop relationships with these people. So I've been on the RUC now for coming up on my 8th year. And so that's the key thing, is getting to know the key players. And you also know who your strident opponents are. There's a few people that historically would just come after us every time, and you know who they are. And you learn how to diffuse them. You learn how to kind of look at them and say, listen, we're all at this table, and that's the one charge of the RUC. You got to take your specialty hat off. So for example, when codes come up for the STS, I can vote on them, but I cannot say a word to advocate for them. So again, it's a lot of it is personal relationships, getting to know people, sitting down with them and saying, what do we have in common? Listen, you want this to go up in E&M, we can support that. For that, we need a little more work in the hernia codes or some of these other codes we see coming up.
We tend to focus on this very small part. We tend to focus on this small.
I'm not against them, but it's just that we are a small part. We are kind of quibbling over crumbs at times, but we got to stand up for ourselves. Otherwise, we'll just be pushing for this.
Yeah, and I saw all these emails go out over the weekend about this 4% cut.
Yep. It's now that we're past the midterm elections, they'll focus on this. Believe it or not, they will by the end of the year. And I think we'll probably get the 4% cut. That will go away, but we're still going to have 4% cut.
Yeah. Well, thank you, and thank you for advocating for us.